Good afternoon. Thank you for joining us this afternoon. This is Kim calling in from ALS Canada. We have 3 speakers today, and we're going to start in about 3 or 4 minutes, so just give us a few minutes to get organized. You can see 2 of the 3 people on the call, and our other guest is on the phone, hoping that her internet will come back on for us. But we'll just take a quick second to let everybody get set up. We know everybody's just starting to log in, so give us a quick minute.
Hello.
Okay, there. Okay, good. I was just like, right next to you. Okay, good.
Can't hear you, Kim.
Okay, I'm sorry. Down on the left-hand side of your screen, there is a chat box. So if anyone has any questions, please feel free to type them in there, and we'll ask our panelists those questions. Thank you so much for joining us. So I'm going to let everybody actually introduce themselves. Stephen, do you want to go first?
Sure, absolutely. So my name is Stephen Jansen, and I am a registered psychotherapist and a psychosocial spiritual care provider from Bethel Hospice, which is a 10 residential bed facility nestled in the village of Inglewood, which is just north of Brampton. And I provide spiritual care for palliative clients and their families while in the community, and bereavement counseling and support for family and friends after a significant loss.
Thank you, Stephen. Dr. Dooler?
Hi, I'm Debbie Dooler. I'm a palliative care physician and family physician, and I work in the outpatient team in Niagara, and also I do shifts at the inpatient hospice for Hospice Niagara in St. Catharines.
And on the phone, we have Mahogany.
That's Mahogany, and it's okay. So my name is Mahoganie Hines. I'm a palliative pain and symptom management consultant. I work out of Hospice Niagara, and I work predominantly with long-term care. I sometimes work in the community as well with the palliative care outreach teams, and I sometimes work in the hospice as well. So I'm a registered nurse as well.
Thank you to the 3 of you and your expertise for joining us today. We're so grateful for you to take the time. And we know this topic is something that has been requested by our community. And so we really think just starting to engage people in some conversation will be helpful. We've had a lot of questions coming out of today's webinar. Just so everyone is aware, we are taping today, and we will be able to share it as a resource after the fact. So I think I'm just going to jump right in and start with Dr. Dooler. Can you explain a little bit what is palliative care?
Yes, of course. So palliative care really is looking at the whole person to monitor for suffering. So that's pain, symptoms, psychosocial, spiritual, looking not only at end of life, but also how can we make you more comfortable and better able to cope during the whole kind of course of an illness, as opposed to the last few days. hospice is, again, what we people think hospice is a place to go for end of life, but what we think of hospice is a philosophy of care where we use palliative care in any setting. So we could have home hospice, we could have hospice in the um, uh, outpatient setting, in the hospital, really any area you can have good hospice care.
So, Stephen, a lot of times there's a difference between hospice and palliative care, and people's hesitation about getting connected to programs like hospice services. Can you talk a little bit about the importance of getting connected with organizations like yours for people who are living with ALS?
Absolutely. Usually, I mean, hospice care is an easy Google search. If you just type it in, it'll show you your local hospice organizations and agencies. Hospitals will have information on the hospices that are available, and community agencies or allied health agencies should also be able to direct you to a hospice. But the best way to connect with the hospice is to call them directly, and or Google them and see the services that are available, and just talk to a representative there, and they should get you acquainted with what they can provide and when they can provide it. Usually, if you're already palliative and you have a palliative care team available, or if you're working with your physician, he should be able to, or a nurse, they should also be able to make a referral to a hospice organization for you.
So, Dr. Dooler, one of the things you said, there's a difference between palliative care and end of life. And one of the conversations that's pretty common within our organization is getting good care, being well supported in advance. Can you talk a little bit about why having those conversations in advance is so important?
Yeah, sure. So I think one of the most important aspects that we need to understand is that nobody can really predict when end of life is. And there's a long period of time between a diagnosis of ALS and, when we are typically thinking of somebody as being more end of life or palliative. But in that time, there are a lot of questions that you may have around either symptoms, or you may have some, psychosocial questions around spirituality. There may be questions really about what your options are and how to be prepared and how for family to be prepared. So I find that having an early discussion around what the options are available allows us to build a rapport, especially while you're able to communicate a little better. It's a little easier to be aware of the options and then make a decision when you're not facing things so urgently. And there's a lot of different options that you can think about to be prepared in advance, that you may not understand without talking to somebody who's experienced that before.
Yeah.
Mahoganie, in your role as the nurse, and I guess both in your work in long-term care and in the community, a lot of people talk about what is advanced care planning, and that's pretty much a random conversation. Can you explain what that means?
Yeah, absolutely. So advanced care planning, oftentimes people think that it has to be a document, but it doesn't actually have to be a document at all. Advanced care planning is having conversations about the person's goals and their wishes and what their beliefs and values are. But the other piece of it is making sure that you've identified your substitute decision maker. So having a substitute decision maker is somebody who can speak on your behalf should you be rendered mentally incapable. And really, it's just identifying what those goals, those wishes, those values, and those beliefs are. So it gives them kind of a guide to what I always say to patients is, and families, is if your loved one could speak right now and they could write down what they want on a piece of paper and they handed it to you, is this what they would want? So it kind of takes the onus off the substitute decision maker as well, because they're not making new decisions on their behalf. They're only actually fulfilling the wishes that have already been discussed or identified as valuable, purposeful, and meaningful for the person. So advanced care planning is really just a conversation, and it's better if you can do it earlier, because as Dr. Dooler has already mentioned, if you're still able to have that conversation, then you can, it just makes it so much easier than trying to figure out at the bedside when it's a critical situation if it's something that your loved one would want. It takes a lot of that fear and a lot of, I guess, the trepidation that comes with end-of-life care and critical incidents. It takes some of that fear and that challenge out of it, so the person can actually just be present with their loved one.
Yeah, and if I can just add to that too, to Debbie and Mahoganie's comments, is, you know, it's never too soon to talk about palliation and hospice care. It doesn't mean it's going to happen tomorrow. You know, and a lot of times when I'm working with families, we start talking about, you know, advanced care planning and end of life, it's like, oh my gosh, we're that critical? No, you know, it's early intervention. You know, well, if the earlier you intervene, the more relaxed and more you're able to process a lot of big decision-making issues. And you need, you know, you need your family, you need your ability to think about this and to take time to talk to family members yourself, to process. And, you know, the more time you have, the better decision-making abilities you have, and the more de-escalated you are. And it's just that much better, so that when you do enter those phases and stages of end-of-life care, you have it already, you know, you've already processed it, you've already talked about it, and everyone is on board, and it just goes so much more seamless, and that continuity of care is so much better than trying to do it in those last stages when everything is a little more tense and stressful.
I agree that also it helps to give you a little bit more control over how your wishes are performed, and the more control that you have, I find that the less, there's not less stress, but there may be more time to allow your wishes to be followed.
Mm-hmm. Yeah.
So with the three of you having experience supporting people who have ALS, is there any particular milestones that you think ALS patients need to consider that they now then need to seek out that palliative designation or those supports? Is there something, you know, should it be done at the beginning of a diagnosis? Is there a process that needs to occur before clients are eligible for that service?
I was just going to say, really, like, just to dovetail as Dr. Dooler has said when she's talking about palliative care, like, palliative care happens from the time of a life-limiting diagnosis, like ideal palliative care, through to bereavement. So making sure that we're taking care of not only the person, but whoever they identify as their family members throughout that continuum, because all of you will be grieving, and it will look different for every single person. Even if you think you know what you're expecting, you might not. And you go through it together as a unit, and we take care of not only the person, but also the family. And I think it's really important that we start those conversations as soon as possible. I like to encourage people, when you're watching TV and you see something happen, say, would you want that? Like, would you want that to happen? Would you want CPR? What would that look like for you? Right? So, like, they're easy opportunities. I also say, don't replace the goldfish. So if the goldfish is doing the backstroke, have a conversation with your children about it, right? Because it doesn't just affect adults, it affects everybody in whoever they identify as their family and their community.
Yeah, and I have a lot of clients that, you know, as soon as they're diagnosed with ALS, you know, any kind of life-limiting illness, like Mahoganie said, we can be active. And so, you know, they talk to me, their symptoms aren't severe, they're still functional and able to be involved with their work and everything, but they just want to know what's available so that when the time does come, you know, they're more educated. And just because we engage with them early doesn't mean we're with them constantly. It's just that we go in, we show them and share with them what we can do, and then when the time does come, they can call us back, and we're a familiar face, we're a familiar voice. We develop that therapeutic relationship, and it's just that much better to engage with again, because we've established that rapport when the time does come. So it's not like we have to camp out on their front lawn until those last.
Dr. Dooler, situations, I think one of the questions we're having right now is actually, can you give us an example of the things that people with ALS should discuss?
Yes, of course. So with ALS being a kind of very complex disease with many different stages, and different stages that are predictable to some degree, but then also the timing may be different for everybody. So everybody's experience is very different. So I think some of the things we need to be talking about with the family members are what is important to you? What do you value in your life? And a lot of times you may feel you're experiencing losses, and a lot of those losses are around things that you used to be able to do that you can't no longer do. And if you talk about them as they are occurring, there are things that can be done to replace those situations. So if you're not able to, go out anymore, so maybe you could have virtual visits with your family, or if you're not able to communicate as well, maybe there's other ways of communication. So I think it's really important to start off with, what do you find really valuable in your life? Because as there will be losses, there may be things that you can do to maintain certain things that are important to you. And then you may have to let go of other things that are not important to you, just so you're looking at it, what is important to you in your life. The other is really who is important to you in your life. So when we have a diagnosis, it often comes as a shock. There may be people in your life that are important that you would like to follow up with, tie up some difficulties with communication with maybe family or friends. Look at things as, who are the people and things in your life that are going to give you quality of life. And then, of course, as Mahoganie said, is to talk about what your wishes are for end of life. And then we talk into things like resuscitation and what your wishes are around that. And then from there is you have wishes for celebrating your life, after you're gone. So there's a lot of different things to consider, but I think the key really is to keep it focused on things that you find positive and add value to use your energy on as a patient and a family.
Dr. Dooler, one of the things that we find in terms of conversations is, what is the next step? What am I going to need next? And a lot of people make decisions very early on in their diagnosis. For example, I don't want a feeding tube. I don't want to use a BiPAP. And how are those people supported? Are they supported different because they choose not to do them versus choosing to go ahead and proceed with having a feeding tube? And how definite is their decision at the get-go? Are they able to change their mind? What does that mean when they go ahead and change their mind?
So, I mean, certainly part of palliative care and part of ALS care, I also believe, is that we follow whatever your wishes are at the time, and you can change your mind. So you may initially say, no, I don't want to do that. And then it's perfectly reasonable to change your mind at the time and say, yeah, you know what, I thought about it. I would like to go ahead and have a feeding tube now because I feel my quality of life with a feeding tube would be still good. And that's perfectly fine. So we have a conversation which is ongoing. So like you had said, if you decide that that's something initially that you want, it's an ongoing conversation. You may then come to the decision again and change your mind and say, yeah, you know what, I feel pretty good right now, and I think I will go ahead and have the breathing machine, or I feel, I do want to continue on with treatments. It's completely your journey and your decision. So there's no right or wrong decision at any point. So as practitioners, it's really important that we understand what your wishes are, and then we do our best to be able to offer you the best quality of life with those wishes.
Stephen, I think there's still a bit of a misconception about hospice in terms of there's a real understanding of residential hospices, but not necessarily hospices that provide support in the community or outreach. And one of the questions we've been just asked is there a hospice that specializes in ALS? And from your experience, do you find that there is a particular place that people should go? From my experience, I would say no, but I want to just kind of confirm with you. I think there's a bit of people believing that there's somewhere they actually need to physically go to possibly end their life, at end of life.
Yeah, I don't know of any hospices who's solely focused on ALS clients, unfortunately. But I mean, most of the hospice do have ALS experience in the community. And so, like Hard House Hospice in Mississauga, there's strictly community palliation, and they have hospice counselors that go in, they assess, they evaluate, they have good conversations with the client and the families. They determine the needs, and then they help with those needs, or help facilitate those needs and advocate. So they'll call up other organizations and agencies to get them on board and try to create a collective continuity of care by other healthcare teams. So they sort of evaluate and provide a little bit of oversight, as well as provide services. So complementary services like Reiki, touch therapy, aromatherapy. They bring in volunteers that will help support them. So there's a myriad of services that you can have within your own home domain. And most people do, by and large, would prefer to be at home when they die. And so a lot of these hospices will try to accommodate those needs as best as they can with the organizations and agencies that are available.
Great. Mahogany, can you speak a little bit? I know that a lot of the clients that you're supporting are quite isolated in long-term care and are needing support. But one of the things that we're seeing now is that a lot of families at the onset of COVID, they were choosing to make some decisions around limiting access of people into their homes, but are now quite concerned about caregiver burnout. And can you speak a little bit to should people let people in their homes to provide care? What can we do to make people less anxious around that?
That's a really good question. And I think I don't know that there is one specific answer, to be honest with you. I think there's a lot of checks and balances that need to come into play. One of them needs to be the comfort of the person and the family, but also to reach out absolutely to the resources that they have available in their community. I would encourage them also, the healthcare providers can reach out directly to the PPSMCs that are in the community, because we will offer that support and that consultation to try and facilitate linkages if we're unable, because we don't take over care for anybody, but we work closely with them. And I think the fear is real with people, but I also think that they need to appreciate that, the healthcare providers that are coming in to see you are also trained in infection control, and they do hopefully have PPE. PPE, I know, is a continued struggle across the healthcare system in every sector. So, I mean, absolutely, just making sure that they're doing adequate hand washing and that they're making sure that they have a mask on. And also, if the patient is able to wear a mask, it's ideal if they can. But I appreciate that if they have ALS, they may have a challenge with that. The other thing to consider is ALS is one of the disease processes that does have a lot of AGMP procedures, which are aerosol generating medical procedures. So BiPAP, CPAP, even like deep suctioning are all considered aerosolizing procedures, which require an N95 mask. So in those cases, we would need to make sure that the healthcare provider has the adequate PPE to be able to do that, just to make sure that they're maintaining the safety for themselves, as well as the safety for the patient and the family. And then as far as long-term care goes, like long-term care, really, like as Stephen was talking about earlier, like hospice can take place anywhere, and hospice can absolutely take place in long-term care. I would argue that the vast majority of long-term care, a huge portion of their patient populations would benefit from not only a palliative approach. I would argue that probably just about all of them do. But as far as hospice care, so that end-of-life care phase, and they are very skilled at it, but that's also why we're here, right? Like you guys as well as ALS offer support to long-term care and to the community. So you're another resource that I think they can be looking to, because I collaborate very closely to the manager in my area, you know, Melissa Van Tile, I'll give her a little props. So I mean, I collaborate very closely with them, and I trust your expertise, and I think many hands make light work. So utilizing the supports and services that are available, absolutely. And if you're concerned, I think voicing those concerns prior to those visits is also really important, and explaining what your fear and trepidation may be, because it's our responsibility as healthcare providers to assure you that you're going to be safe, and we're going to give you the best care possible in the most safe way. Does that answer your question?
Absolutely.
Yeah.
Stephen, my question, oh, sorry, go ahead.
And just to add that too, a lot of times my clients feel like, and it's not an either or, they feel like, oh, if I get community hospice care, then I can't go to a palliative clinic or a residential hospice, or I can't go to the hospital. It's not that at all. You know, it's where you're at is, you know, where we want to be with you. And if you're in the community, we can provide hospice care. And then if that time comes where your healthcare needs supersede your caregiver's ability, hospice care is an option, or the hospital is an option. Or sometimes, you know, people, they get better and the residential care, and then they get discharged and they go back to the community. So, you know, it's a very fluid situation, and, you know, it's my experience is that we try to meet, you know, it is that client family-centered care that we try to meet the needs and be flexible to work with wherever they're at.
And who makes that decision around residential hospice? Is that something you would have a conversation with your palliative care team around whether or not that's an option, and what are the timelines for that? Would that be something that you would discuss with that team?
I can speak to that if you like. So for the admission into residential hospice, the way our hospice, and I think most hospices work, is that each person is looked at upon at that time to see if they would be a good fit for the hospice bed, if there's a bed available. So it's an ongoing discussion. So if you say you think you like to be for end of life at hospice, you would go on a hospice list through the LHIN, and then those hospices look at the list every week or every time there's an empty bed, and say, who is the next most appropriate person that could benefit from this bed? And that's an ongoing discussion. So it would involve really looking at the situation from day to day, really. So it's really the hospice will decide whether you are appropriate at that time and whether you would benefit from being inpatient. So it's not somewhere you would want to go for like an extended period of time, because, you know, it's more of a, is it towards end of life? And it's difficult really to judge that, and every person and every family is different. And that's why it's an ongoing conversation between the family and the patient and the hospice and their caregivers. really, there's no real one answer to that.
Stephen, can you, we've seen an increased amount of fear and anxiety around COVID within our community, and I think that's just probably actually across the general population. Is there ways that we can help support people in dealing with the emotions of the uncertainty of what's happening? And it may not be just end of life, but just in general, how are people, the skills that they need to be able to cope with this?
Yeah, you know, it's as I'm talking to my clients and as I'm talking to my colleagues and listening to how healthcare agencies are trying to cope, it is a stressful time. This is not normal. We're not used to this kind of environment, and especially for hospice care. I mean, we're a huggy bunch of people. It's all. I feel, when I'm talking to people on Zoom and on the telephone, I feel like I'm handicapped because all those nonverbal communication skills that I have, I can't use because, we're over the phone. And it's very distressing. And in a way, I think, as a society, especially with people who are experiencing illness, that isolation is crippling. And I think we're all grieving, a significant loss in a way that, the people that we once were and how we used to give care, we can't do like we used to. And we feel that, and it affects us. And so, that fear and that anxiety is just compounded with the stress of just trying to live with illness or life-limiting illnesses. So, the best thing, is contact, connecting, and helping people stay connected to the things and the people that they love, to the things that are sacred to them, to the values, the beliefs, the traditions as best as possible, and talk, communicate these fears, express them, share them with people you trust, and in a safe place. That's the imperative thing. You can't do it in front of people that will judge you or ridicule you or make fun of it. These are important emotions to have, but to be able to share that vulnerability needs to be done in a safe place with a safe person, so you can explore those feelings. And I just have a quote here by Bill George. He says that we don't know who we are until we hear ourselves speaking the story of our lives to those we trust. And when you have a complicated illness such as ALS, this is a illness that robs you of the things that you once knew yourself to be, and you have to tell your story to rediscover who am I now with this limitation, or who is my family, and then family's trying to discover who they are with their loved one, and all of that needs good, healthy verbal conversation and expressing of feelings that won't be judged, and that won't try to be solved with the cliches, but we'll just sit there and listen, actively listen, and show empathetic care.
Very good. Thank you.
I'd like to just add to that. I totally agree with Stephen, and I think these are unprecedented times, and it's okay to express. I agree, express how you're feeling, and I think it's really important. And it's okay to say that it's unfair, because it is unfair, and there is isolation, and it is really difficult times. And there might not be a lot of really great answers coming out, but I really think it's important that we do share how we are afraid, and how we are isolated, and how we are just unsure in these unprecedented times.
Yeah.
And seek out help.
Absolutely. And that's the common denominator we all share. We're all going through this together. We are all struggling, and to be able to have that freedom to share and to validate and to normalize can really help us de-escalate, and that's what we need. When we are escalated and we're stressed, our decision making is highly impaired, and and we become more primal and reactionary in our decision making, and we don't think good then. So it's really imperative to be honest and transparent with everyone, even as as practitioners, when we talk, because it's just we just do not do good as a human species when we become highly reactionary, and we either that flight and fight or freeze and response takes over. Then we're compromised.
Mahoganie, sometimes I find that when I go to clients' homes to have conversations, they're clearly not ready for some of those conversations, and it needs to be done on their time. And sometimes you have family members who are very much an A-type personality and want to have those conversations and are very open. How, as either family or people in my role, for example, how do we get the client comfortable in having some of those conversations and really having it in a timely manner that is not waiting till crisis mode or desperation kicks in for everyone? How do we start those?
Thank you for that question. I think in my experience, especially bedside nursing, what I found is we too often don't employ this skill is silence. So just actually learning how to hold space and be present for somebody and just kind of let them work through their emotions, especially if somebody has a diagnosis of ALS. They may have difficulty speaking, or they may have a time requirement where they need to process and they'd like to articulate their words very calculated. And we need to give them that time and that space to be able to work through. I think, and I don't necessarily think as healthcare providers, sometimes we forget to do that because we have tasks and we get very task focused. And I think, especially in nursing, we talk about the art and the science of nursing, and really where they marry is learning how to employ those tasks in a way that's still beneficial and meaningful and meeting the person where they are in a way that's meaningful for them. You absolutely, if it's something that's time sensitive and you anticipate that somebody is going to potentially maybe progress, you can also say that, but you also need to give them a bit of space to kind of metabolize it, I think, as well. And sometimes we expect answers right away. And sometimes they don't have the answers right away. They don't know. They've just been given a bomb and they're still kind of working through it. And we can't expect that they're going to be able to answer it. So sometimes what I've done is I've worked with the family and explained, you both have different communication styles, and that's okay. We all have different communication styles, but what your family member needs most right now is for you to be present. And you can definitely continue to talk about it. Maybe now is not the time. Maybe the setting's not right. Maybe the environment's not right. Maybe they're just uncomfortable. Maybe they're short of breath. Maybe they're hungry. Maybe any number of things can impact the way you have a conversation with someone. So I think giving them the opportunity to come about it in their own way. Sometimes I'll give them a bit of a time limit and say, okay, maybe by next visit, do you think that we could discuss this again? Can we address this? This is where I kind of am anticipating you may be. So I want to make sure that we know what you need. The other thing that I often do, and this is part of advanced care planning as well, is I take the onus off of the person and say, realistically, it's not even about you per se answering the question. It's about you being able to help your substitute decision maker make that decision for you. And should you not be able to speak or mentally capable to do so, then we want to make sure that they're equipped for success, right? We want them to be able to successfully impart whatever it is that you want for your wishes. And the only way we can do that is if we communicate it. And that communication may not be through words either, right? So sometimes it's a look, right? And the family members are so good at knowing what that looks like. That raised eyebrow is you're in trouble, right? So trusting that their family members are the experts in the communication with them is also really important. So I think, unfortunately, I'm not giving you a really quick, nice and easy, tangible answer. But in my experience, those are the things that I find are helpful when we're trying to have difficult discussions that maybe people aren't ready for or just don't have an answer to. You can't force an answer out of somebody, but understand that also, even if they choose, like Dr. Dooler said, they can change back. They may change their mind, and they may change their mind 16 times before you come back and visit. So talking to them about that and saying, it's okay, this is a normal process to go back and forth. It's totally normal, and it's totally okay, and it's your journey. We're just here along for the ride. You let us know how you want it to look.
Yeah.
I think that's really great advice. Do either Stephen or Dr. Dooler, do either of you have any comments around a family member engaging that conversation? Who should be the people having those conversations? Who should be the starters?
Go ahead, Dr. Dooler.
Oh, thanks. Yes, that's a good question. So I think it can be anybody, really. It can be a family member, it could be a counselor, it could be a really good friend, it could be the palliative care team may come in and just say, have you thought about what your wishes are, to think about these different things. So really, it can be anybody. It can be whoever is the most comfortable, really, to kind of get those things going. I think it's important as practitioners that we always bring about the conversation. So I feel my job is to ask the hard questions, even if it is uncomfortable. That's not expected of family members or friends, but it is expected of me as a professional to ask those difficult questions about what are your wishes around end of life, and have you thought about the future and what that would hold. So I'm very comfortable doing that. Sometimes when they don't really know which way to go, you could have some stories or examples of other people that I've looked after in this type of situation have, done this or that. Conversely, in the same situation, a different person has done something different. So there's no right or wrong answer.
Mm-hmm.
But just opening the conversation is important for anybody who feels they're comfortable doing it. Otherwise, I think as the practitioners, it is our job to talk about what the options are. And sometimes what I do is I'll start with the options, what are available, a do not resuscitate order, do you want to have a feeding tube or breathing tube, all of this. And I say, that's something to think about. And like Mahoganie said, I said, talk to your family members, kind of see where you're at. And I'll come back in a week and we'll talk a bit more if you've had any questions. And usually what happens is people will think about it and they'll come up with some questions. And then you go back and you'll answer those questions. And you say, okay, well, think about it again. Now you've got more information. And we'll come back and readdress that, in another week. So I think it's more of an ongoing conversation, and I don't really expect people to give an answer immediately off the top of their head, but it's more an opportunity to ask questions and kind of see what knowledge you need, what information you need in order to be able to make decisions for your future planning.
Thank you.
Yeah.
Stephen, one of the questions that's just been asked on the chat is, does going to hospice or accessing any hospice services cost money?
No, and this is the best kept secret. As far as I know, most hospices don't ask for money. They'll ask for donation afterward because a lot of their funding, or 40 to 30% of their funding, does come from community outreaches. But they are subsidized by the government, 60 or 70%. I'm not quite sure the exact figures, but no, there is no cost to the service. And that's I think that takes a tremendous stress off the family, that there's no financial burden here. And it's most hospices, correct me if I'm wrong, Mahoganie and Dr. Dooler, but their community, a lot of volunteers run them, and which I think speaks to the veracity and the authenticity of or how effective the hospice is, of how it connects to the community. and it's just it's a wonderful place. I know end of life. No one wants to talk about end of life and death, but you know, there's a huge difference between hospital and hospice. Hospitals are mostly geared around helping a person get better, about healing, about restoring, and everyone's mindset is about getting this person better. And so it's really hard when you're end of life in a hospital, because it's more frenetic, there's more bells and whistles, it's more distracting. Family members can't quite connect in a way that is meaningful with their loved one, who may be in a room with multiple clients in different stages of life. And so hospice, you know, family members are there. The environment is about the family member and the client, giving them dignity, respecting their space, and giving them the amenities so that they can be there with their loved ones as close as possible now with COVID-19. There's restrictions obviously now, unfortunately, but you know, so it makes a huge difference, and yeah, it doesn't cost a dime.
I always say hospice.
Oh, I'm sorry.
So typically it doesn't cost a dime, but most hospices will either take like a credit card or a small deposit just for if there are any medications that are over and above that are not covered,
Okay.
or if there's any treatments. So it's normally a very small amount, it's a nominal amount, but for medications that sometimes aren't covered, if we normally try and explore all of the medications that are first, but sometimes they're just not, because we don't have a universal pharmacare plan. So because some of those medications are not covered, we may end up having, and if they don't have like additional third-party insurance, it may not be covered. So they may need to pay just a little bit of a differential. So sometimes we'll take like a deposit, but if it's not used, it's reimbursed. Or if it's not needed, because it depends on the hospice and their policies. Some hospices will take a credit card and they'll say, we'll call you if we need to make that expense used. Otherwise, they won't. Others will take a small deposit, and if that deposit is not used, they'll be reimbursed it after the person has either been discharged or they have died. And then hospices are absolutely, like, volunteers are the backbone of hospice, but they are run by registered staff. So I just wanted to clarify that, just because somebody might not know. But we absolutely, like, a huge portion of how we do our programs and how we support our residents, and then all of the community outreach. Like, we have huge amounts of volunteers that help us do really amazing programs and do really amazing things for not only the people within the residence, but also the community that also uses our services. And then, yeah, normally the residence has PSWs and nurses and physicians and director of care and psychosocial bereavement clinicians. So we have a really amazing intercollaborative team. So I just wanted to clarify those 2 points.
Thanks for the that's right. And Bethel Hospice, they have attending physician and the nurses and PSWs available, as well as social workers in the community. So thanks for that clarity, Mahogany.
The only other charge is you may need to pay for Ontario patient transport, which is not covered. So if you're not able to go in the car with your family, you may need to pay for transport to the hospice by OPT.
Yeah, and that's if you're going out as well, because sometimes people will get like a treatment or something at the hospital, not during the time of COVID typically, but if they need to get like a specific intervention at a hospital and come back, they may have to pay for OPT as well.
Those are so helpful. Thank you to all of you for that feedback. Dr. Dooler, one of the questions we're having in the chat was how to have a conversation about a trach, or where information can be found about educating themselves on that. And I'll let you speak to it, but I also, if there's resources, we will happily send those out after to people who've attended the webinar. So if there's things that you want to share, that would be great.
Okay, yeah. So that's a really good question. And often I think one of the questions would be looking at the risks and the benefits. So whenever you're looking at any type of intervention. So if it's a trach or a feeding tube or a breathing machine, is what is the risk and what is the benefit to that? So you really have to discuss that with your physician at the time to see what the exact, what are the risks and the benefits. I mean, there's risks and benefits of having a trach and risks and benefits of not having one. So, you really have to look at what the individual benefits are going to be. So some of the decision-making factors certainly would be, would it improve breathing? So, obviously that's why you would have it. So you'd have a tube that goes in to help to attach your breathing machine to in order to help with breathing. The other would be, is it more helpful for deep suctioning of that if that's a problem? And then you have to look at the risks of, is there a risk of infection versus the risk if you don't have it of aspirating. So there's lots of different things to think about. But the key really is going to be looking at, will this trach improve your quality of life so that either you're breathing better or you're, not suctioning as much, or is, if you do have it, if you don't have it, how will that impact, your quality of life? And so I think the keys there are, what is the risk of having it and how will it benefit you and how will it improve your quality of life? So sometimes you want to say, is it something that will extend my life? So if I have a trach, will I live longer? That's another great question. Is it something that will either make me breathe easier, or is it just, something that would benefit in some way? So I'll see if I can find some resources for that. But in general, it's a conversation with your clinician at the time. If there's a blockage or something and it's urgent, well, then clearly you have to discuss the risk of having it and not having it, and then decide from that point whether it's something that is something that you want to do.
Perfect. So I want to take a little bit of a switch, and I know we're talking a lot about palliative care, and I want to talk a little bit about MAID, because that's a conversation that a lot of people are having. And maybe I'll start with, is MAID part of palliative care? And Dr. Dooler, do you want to address that one?
Oh, sure. Yep. So in preparation for today, because I know you have questions about MAID, a few things. One is you have questions about MAID in general, and then questions about how is MAID impacted in COVID, and also how is MAID specifically different for ALS. I think those three different things. But how is MAID a part of palliative care? So part of looking at planning for end of life and making sure we know what your wishes are and follow your wishes, we have a conversation about the different aspects of end of life in order to make you comfortable. So certainly MAID is part of palliative care. So practitioners who do MAID might not be palliative care physicians, but we always refer and counsel and talk about it and are part of, the decision of making that decision. We can be helpful there. So medical assistance in dying is basically a procedure that you would have. I can explain it a little bit. It's a medical procedure. You can have the procedure done in your home, in the hospital, in another outpatient setting, and you make the decision regarding the timing of your death. So a lot of what we talk about in palliative care is allowing natural death. So what that means is we determine that we're not going to have any interventions that will either prolong or hasten your life, and we allow your natural death. So with medical assistance in dying, what that does is it does hasten your life. So it is a procedure that you have done at a set time. So you say, yes, I'd like to have MAID next Tuesday at 2 o'clock. And then you have your procedure. And then at that point, you'll die shortly after that. So that's the difference there. So it certainly is something that is a personal preference and something that we talk about a lot, what the differences are. So for palliative care, like I say, we have the allow natural death. So your body takes its own process. Then we have medical assistance in dying, where you make the decision and say, yes, I have a time frame and I would like to have the procedure. And then the other thing we talk about is terminal sedation. So at end of life, you'll have some medications that keep you very sedated into a coma. You stop eating and drinking, and then you kind of your body allows natural death that way. So specifically about medical assistance in dying, there is, some questions. I know we had some questions earlier, which I think I'll just address it now. So the criteria for having medical assistance in dying, I think, is important that we talk about. So it's a federal program, but we'll just talk about Ontario since that's where we all are. So you need to be 18 years of age. You have to have an OHIP card. You need to be capable of making healthcare decisions. So that's called capacity. And you have to have a grievous or irremediable medical condition. So a grievous or irremediable medical condition is pretty vague, but there are 4 stipulations with that. One is that it's a serious and incurable disease. 2 is that you are in the advanced stages of the disease and you are starting to become incapable of living a regular life. 3 is that you have a physical or psychological suffering. And 4 is that your natural death is in the reasonably foreseeable future. So those 4 things really they're pretty vague again, but it's those are the important factors. So in general, the request has to be made by the person, so it has to be voluntary. So somebody cannot coerce you into having MAID or requesting MAID. And you have to be able to provide informed consent. So informed consent would mean that you understand that when you have MAID at the conclusion of the procedure that you will have died, and that you understand what the other options are. So you understand that there are other options and you've investigated those. And one of those other options, of course, is palliative care options. So that's a lot of information. So the way you access the program is you would contact the care coordination. There's a number for the government, and they will match you up with a MAID provider in your area. That would either be a doctor or a nurse practitioner, and then they would contact you. And there's a lot of legal forms to be filled out, a lot of assessments to be done. We can talk about that a little bit. So part of the questions that we had was, is COVID affecting how we can access MAID? So I spoke with Julie Campbell. She's the provincial MAID coordinator, to get the latest on the MAID program during COVID. And so we had a nice conversation. So the bottom line is that COVID is not having an impact on whether you can access MAID. There was a very brief period of a few days where Ottawa Hospital had decided they were not doing program, but that was very short-lived, and it was a lot in the media. But the impact of that is that nobody in the province has not had MAID because of COVID, so it's available. The other question that came up out of the media is there a shortage of medications to provide MAID due to COVID? And the answer to that is no. Medications are available. the pharmacies have a backup stock, like a stockpile of medications should, COVID become a little bit worse here, where their medications are being used in the ICU, but there is a backup supply there. So no, there's no medication shortage for that, which is great. We were concerned a bit about that, but that is just fine. And currently, MAID is still available in all centers in Ontario. There have been some changes though because of COVID. Some of the assessments may be done virtually, so either on the telephone or on virtual Zoom or whatever it is, as opposed to face-to-face. And there will be the need to follow provincial guidelines on gatherings of 5 people or less. So if you are having MAID in your home, initially, before COVID, you could have as many people as you wanted. You could have no people, you could have all your friends and family. But now they are limited it to maximum of 5 people, as guidelines are for the province. So when the guidelines in the province change, then that will also increase. That's in the home. So the way they're doing that really is you think about who you want there. Now, there's also the opportunity to have virtual visits as well. So you could have your family, your friends virtually there for your MAID procedure, if that's what you want. Otherwise, they are taking time blocks where you say, well, okay, we're going to have, say we have 10 family and friends, but we can only have 4 at the bedside. We'll take some time. So each person, can come and have an hour and then not exceed the total. So there's lots of ways of doing that. The other difference that we're having too is that part of the process of having the MAID application is that you need 2 independent witnesses that are not your family and not your medical team. Oftentimes people will take neighbors or friends or somebody. So they are allowing those to be signed virtually. So there can be some virtual signing done on those because sometimes it's a timely manner to get this signed. And that's pretty much, so that's all really good news. Now, there's some statistics. So MAID, the Bill C-14 became viable on June 16, 2016. In Ontario, there's been 3,000 cases, and as of April 30th, 2020. And 11% of those are considered neurodegenerative conditions such as ALS. 63% are cancer related. Still the majority are cancer. The youngest case in Ontario was 22 years old and the oldest case was 106 years old. So there's a wide variety of situations where having MAID is been very widely used. So I can give a little bit more information, but I thought the other thing that I thought was quite interesting is that currently hospitals have a no visitor policy due to COVID. That is a difficult situation if you wanted to have MAID in the hospital. The policy is that there's no visitors. So what they have done is, in some situations, they have utilized funeral homes in the community. And that has worked out very well to have your MAID completed. If for whatever reason you don't want to have it at home or you can't have it at home and you want somebody to be there, so you don't want to have it in the hospital. So funeral homes have been have some advantages. They have a very nice setting. Often there's a nice place there. The funeral directors are very well versed in understanding and dealing with end of life and bereavement and grief. And also you don't have that same limitation as the hospital for visitors. Of course, you still have the provincial guidelines, which would be the same. So I thought that was a really interesting use of the funeral homes. And pretty much I spoke to two MAID providers just to get a little sense of how they're working through COVID right now. And they both said they're doing the best they can to do timely assessments either virtually or in person with protective equipment, but timing may be a bit more challenging, you know, because of the trying to get everything arranged. So sometimes you might want to think about it a little bit more ahead of time to get your assessments done, because when you've had your MAID assessment, you have your first assessment and then there's a 10-day waiting period. And then you can have your MAID procedure done. But if you have your first assessment, you don't have to have MAID. You could wait, you know, for 4 months or 6 months and have it at a different date. So with ALS, one of the main questions is, how is it different? So timing is different because communication might be a challenge at a later date. So accommodations can be made for communication. That being, you don't need to be verbal in order for the assessors to determine that you're competent and capable, but you do need to be able to prove that you're consenting to this. And I mean, I've been involved in a few cases, sometimes at the point where you can only blink eyes, that's okay, as long as the assessor understands that you understand and that you are responding appropriately. And the other thing that I think is important to know is that when you have a condition, you don't have to have physical pain. You don't have to have psychosocial suffering. You can have loss of independence, and that's a perfectly valid form of suffering. So it's important, I think, that you express to your assessor what it is that that is most bothering you, and that whatever is most bothering you is the most important thing. So that might be, I have this loss of independence. This is not good quality of life for me. Or I fear that I'm going to be a burden and I don't want to be a burden. Or I fear that I'm not going to be able to breathe. And those are valid reasons. So when we look at reasons for suffering, the suffering is personal to you, and it's really important that you are able to articulate just what is bothering you, and that if you have a good assessor, they will be able to take that what is bothering you as your suffering, even though you might not be able to articulate exactly what it is. And the other thing that I think is important to know about MAID is that the job of the assessor is to determine what your wishes are and do the best job for you. It's not to be judgmental that your suffering is not good enough or you need to be suffering in a different way, but they need to be, the providers want you to know that they're compassionate and they're trying to do their best job so that they meet your wishes. And that's pretty much it. Now, having been involved in MAID cases as a support person, what I also think is important is that you may have questions about the procedure itself. So what I can tell you is that the procedure is painless. There's no blood. You don't have a loss of incontinence. It really is, you have the injections, you have the time to have your family say goodbye to your family, whatever it is you want. There's many different things. And then you basically just close your eyes and go to sleep. And that is very peaceful. And it's not traumatic for family to witness. It's not a difficult passing. So I think that was important that the assessors wanted me for you to know that it can be very peaceful. And in my experience, what I found with medical assistance in dying is that it does allow you a certain amount of control in how you would like to pass and when, and the scenario, and what would you like to listen to. You may have certain music or certain people or a certain setting, and that I think allows quite a bit more control that you can make plans for. Which again brings me to the only other thing is that the where am I? It's, I think, important. Again, we go back to, in these very, very difficult times, is that your only job is to worry about how to celebrate yourself as a person. So if you're considering MAID, you don't have to worry about how do I get the assessment, how do I fill out the forms, how do I get the medication. That doesn't matter, because as practitioners, we take care of all of that. The only thing that you have to worry about is how can I celebrate my life? And that is who is important to me and what is important to me, and are there things that that we can plan and have control over. And that sometimes, like I think Mahogany and Stephen had said, that would be maybe leaving a legacy, or talking about some palliative care kind of end of life things that you could do for your family members in order to leave in these challenging times. I think individualize what you can do and take a little bit more control. So that's pretty much it. And then I did want to say that the ALS Society has been really just so huge for our communities to allow us to come in and help provide some quality of life and counseling, and to really help people with all of these types of questions, that they're hard questions, and it sometimes is difficult to articulate what you want to know because you just don't know what's out there. So I really like to thank you for doing this today.
Oh, thank you. But one of the questions we had was actually very interesting, is that if someone starts with palliative care services and they have a team engaged with them and supporting them, but at the end of the day, they decide to change their mind and they want to go with the MAID route, does that mean those services are cut off? What does that look like for somebody in terms of the transition? Because even if the person made the decision that they want MAID at the end of the day, but they've decided it might be a month down the road, how does that look like? Do they just get discharged and say, you're on your own, let's, see how that goes?
Yeah, no, from my experience, we're part of our nurses and our counselors and our physicians, and we're all still part of everything right to the end. And for my cases, for my patients, I often will also be there as well as a support for the family. I don't do the procedure, not part of what I do, but I'm certainly there to support, be supportive. And so right up until, because we're still managing symptoms. So we're still making sure that you're comfortable and everything feels good and you still want to talk about it. And so we're still managing symptoms and being supportive, even after death into bereavement. So we support families as well. And that can be comforting if you know that you're going to continue on, supporting the family as well.
So, and just to dovetail off of
Perfect. Thank you,
Dr. Dooler, in a hospice setting, the hospice is, so palliative care is not, MAID is not considered part of palliative care, but palliative care is part of MAID. It needs to be a part of it. It's an integral part, as Dr. Dooler said. So if we're already caring for somebody and we're providing palliative care, we're going to continue that. We likely will not be the ones that are performing the procedure. However, before, up to, and after, we will be there. So there's still a soft landing space. In a hospice environment, it's a little bit different in the sense of the hospices, as far as I know, in Ontario at least, do not perform MAID in the hospice residence. That being said, it doesn't mean that we're not going to provide excellent palliative care up to and still continue on with bereavement supports for them after. However, likely they will be discharged, and oftentimes they'll go home to receive the procedure at home, or sometimes they were going to hospital. I know policies continue to change around that, but I know that as far as I know, the hospices do not perform MAID because it's not considered part of the palliative care approach. However, our approach to care is an essential part of that, if that makes sense. I know it's a little bit of a linguistic trouble, but absolutely, there's always a place for palliative care when people are receiving MAID and when they elect for it. And should they decide to elect for it, that's absolutely their prerogative. It's our responsibility to make sure that we're still doing exemplary palliative and end-of-life care. And that's, as I'm sure Stephen will speak to, through to bereavement is a really essential part of it, making sure that we have a soft landing space, not only for the person up to the procedure, but for the family after.
Yeah, and if I, that's sort of a similar, my experience with Bethel Hospice too. Bethel Hospice will provide palliative and comfort care, sedation, palliation as well. And they'll even help facilitate the discussion. And I've been a part of the facilitation of talking and starting the discussion for MAID, and then bringing in people to do the assessment on site. But the act itself, because of the sensitivity of in the community as well, they prefer to have, or the person will have to go off site to perform the act. But that doesn't mean we don't go along with them. I've been asked, I haven't done it personally yet, but I have been asked, and I'm planning to be with the person, to be there with them at that time. And that's what I find most crucial. What Mahogany was saying and Dr. Dooler was saying is that that sense of care up to that last breath, and then care for the family afterwards. That's imperative. Abandonment is the worst thing that anybody needs to experience at this stage of life. And to be there, I consider an honor and a sacred duty to show that they are connected to that last moment, to the release into wherever they, whatever the next is. And for bereavement, for families, and also for the client, it's a great sense of comfort knowing that family and friends will have care afterwards. And so far, when I've been talking about with family and friends who've experienced MAID for their loved ones, they most of them have had a very positive experience and very edifying experience to be able to say goodbye in that kind of controlled and comforting way. And I think the hugest thing is just orientating and educating not only the client, but also the family that is maybe at different stages and phases and their values and beliefs. All of that might be different. It takes some time to coalesce and for them to come on board and be on that same page to support each other. That seems to be the biggest struggle right now. Is you have family and friends that have competing or conflicting traditions or values, and that takes some time to work through.
Absolutely. Dr. Dooler, one of the questions we're having is when someone has decided to pursue MAID, who really makes the decision whether or not, who makes that final decision to say, yes, you can access MAID, or no, you can't? Is it based on just the assessor's information and them gathering that information from you and your, for example, your family?
That's a good question. So the provincial standard right now is that there have to be 2 assessors independently doing their assessment. So they go through a full assessment of pretty much everything that they think is necessary. And at the end of that, they put the question is, does this person qualify for MAID, yes or no? If they say yes, then that's one assessor says yes. Then you have another independent assessor who does the whole thing independently as well. At the bottom, it says, does this person qualify for MAID, yes or no? And they say yes. So you have 2 yeses, and then that person qualifies for MAID. So you could have it where one assessor says no and one assessor says yes, and then you don't qualify for MAID.
And is there an appeal?
Or you have 2 that say no.
So is there an appeal process or something if someone, if one says no and one says yes, for example?
I mean, you could have an appeal process. So you would go through your coordinator. So when you sign up for the MAID program, you'll be given a coordinator, a provincial coordinator, and they're the ones who make your assessor. They match up the assessors with the people that want MAID. So you can certainly go to them. Now there have been cases where maybe right now you don't qualify. Depending, I mean, there's lots of reasons you couldn't qualify, but you don't qualify, but maybe a few months from now you would qualify. And I think a couple of the reasons that you wouldn't qualify, most commonly, one is that, so we'll go back to there's really only two reasons you wouldn't qualify. One is that you don't have capacity to make healthcare decisions. And two is that you don't have a condition that meets the criteria for being grievous and irremediable, or possibly your natural death is not foreseeable. So it could be that you have a condition, say you have ALS, which is a serious and advancing disease, but it could be that the assessor says, but you're so early on in your diagnosis that your natural death is not foreseeable in the near future. I mean, if you have a diagnosis, then it could be that you have maybe 5 or 6 years, it's very slow progressing. They may say, well, no, that's a bit too early and I don't think you qualify. The other could be that your capacity, so it might be that you are not able, so they deem for some reason that you can't make decisions for your own health. And that could be dementia or delirium or confusion, or you're just not able to make a capacity decision. That capacity can be fluctuating. So what that means is that at certain times, if you're confused or you're delirious because of a medical condition, at that one moment when they do it, you might not have capacity, and then later you might be clear, and then your capacity is different. So those two things are really the only things that you wouldn't qualify you.
So
And they're both changing
for people to make that decision.
Sorry, say that again?
So there's no timeline for an individual to say that this is the time I need to access MAID, or it's based on the conversation with the assessor to help guide those conversations.
So the timeline really is that you have your assessment right now. So you have your assessment today, you have to meet criteria. Now there is a 10-day waiting period. And at that 10-day waiting period, before you have MAID, you also have to meet the criteria. So part of losing capacity is a time difference. So say today you might be capable of making a decision. You're not confused. Yes, exactly. I know what I'm talking about. This is what I want. I understand the consequences. So then 10 days later, when you're about to have it, maybe you're unresponsive or unconscious, or you can't. You're confused, you're not able to make that. So the capacity fluctuates and changes. I mean, the condition that you have with ALS does meet the grievous and irremediable, but it might not meet the timeline of reasonable death in the reasonable foreseeable future. So if you're looking at many years, then they might say no, that's too early. But down the road, you can apply for another reassessment.
I want to switch topics. The questions are flying furiously on this topic, and I think we could go for hours. But I want to talk a little bit in the last few minutes. Maybe Stephen, if you want to start. One of the questions we're having is what supports are in place when I'm not here for my loved one? What does that look like in terms of providing those resources for families?
So I didn't quite catch you. What support resources are available when I'm not
for
there
families after their loved one has passed? So in terms of explaining a little bit about bereavement support.
So that's one of the things that I provide is bereavement, and for any significant loss, usually human loss, but I have also provided bereavement support for pet loss. It's all about attachment, and sometimes if you're attached to your pet, it can have a significant effect on you, and especially at the right stage and phase of life. So and I find for palliation to provide bereavement support for the caregivers who've been on the journey, especially for ALS loved ones. That you talk about, caregiver burnout. This is a real serious situation for loved ones who've had for family members who've had loved ones who have had ALS. They need support. They need counseling a lot of times because they gave it all they had for that person, and then when it's all said and done, and they go home and the funeral's over and the friends have sort of gone on their way, they have a really hard time coping. And so to be there and to help counsel, to help them work through their loss and some of the anxiety, some of the depression that they might be going through is instrumental. And helping them develop good coping skills, positive coping skills instead of bad coping skills is essential too. It's crucial for caregivers, and I really want to stress this to take that seriously, because if you don't take care of yourself after you've done everything you've possibly did to take care of that loved one, your body deteriorates. Your immune system is compromised, and I see a lot of my clients sometimes so stressed and so anxious because of the grief that and their short-term memory is compromised. They aren't paying attention and they run through stop signs, stop lights. It's just like and then they hurt themselves and they hurt others. It's the worst thing that a person can assume that they have to do is just get over it and get on with life. And so it's an honor to be there for them afterwards and share and help them continue to live, but learn how to live differently, and continue to love, but learn how to love differently, and find meaning and purpose in a different life than they had before.
Thank you. Mahoganie, do you have anything last kind of final words that you'd like to share? Or
I was just going to touch on the funerals and cemeteries because I know that there was a little bit of a question about it. So one of the resources that I often use is the Bereavement Authority of Ontario. They're a really good resource. You can go to them for Ontario. I know this may be Canada-wide, but typically there is a bereavement platform, and what they have is they kind of talk to you about funeral services. So currently funeral services at the gravesite is no more than 10 people, and they need to be socially distanced. If it is not actually a burial, if it's just like another type of ceremony, then it's a maximum of 5, and that's for visiting as well currently. And you can find that information because it's updated on the Bereavement Authority of Ontario. And then if you have any questions about advanced care planning, you can go to advancedcareplanning.ca. And the good thing is that's Canada-wide, so you can pick your province and it will tell you about the legislation for each province, because we're specifically talking about Ontario, but every province has different language and they have different legislation. So just to ensure that you're adhering to that, it might be a helpful, and they have workbooks that families can go through and they're free to print off. So they're wonderful resources. And thank you so much for everything that ALS Society continues to do to serve some of our most vulnerable populations. We honestly, we look to you so often, and we are so grateful for the privilege of being able to speak here and to be able to support you and to support the people that you continue to support every day. So thank you.
I want to say thank you to each of you. Thank you for spending an hour and a half with us. That literally flew by. I can't believe it. So I appreciate that you've all taken the time. I think clearly this is starting a conversation, and the great thing about this is that we're seeing a lot of comments coming out of this. So if there's people on the webinar that have more questions, reach out to ALS Canada. If there's something specific for any of the 3 panelists, we will reach out to them and direct your questions. But we just want to thank everyone for joining us today. And please have a nice rest of the day. So thank you.
You too.
Thank you so much.
Nice
All right,
meeting you.
bye-bye, everybody. Take
This is
care.
Stay safe.
Stay
Bye.
safe. Bye-bye.